introduction to 12 lead. And we'll talk about some key concepts that you as a paramedic student are going to need to know or at least understand. Now this is just an introduction. We'll explore other avenues of 12 lead a little bit more in depth later on. So in this video, we're going to describe the purpose of 12 leads. We're going to talk about the difference in the bipolar, unipolar, and the chest leads. We're going to describe the placement for the 12 lead ECG and then describe the procedure for 12 lead acquisition. So why use 12 leads and why does 12 leads matter? So for this, as far as ECG and what we see is a standard limb lead, so standard 3 lead ECG. So if you think back and what we're looking at for basic cardiac monitoring, we're just looking for basically daily rhythms, right? We're trying to figure out is the heart rate slow, is it fast, is it normal, what rhythm are they in? So 12 lead digs a little bit deeper into not just what the rhythm is or helping confirm what the rhythm is, but also is there anything going on in the heart muscle, and that's what we're trying to figure out. Or is there anything else going on, period, with the patient? So it provides a complete electrical view of the heart, and without more views, you may be missing significant information. So 12 leads are not solely used just to try to confirm an MI or rule out an MI, because that's not what that purpose is. We can look for other means to the blood branch block. Is a patient at higher risk of sudden cardiac arrest, etc. So, in 12 leads improve patient outcomes. We have faster activation of cath lab in some regions and some services. And a 4-lead ECG only tells part of the story. It does not tell the whole story. So if you're looking for a house and say you're out shopping for a house and you drive by this house and think, wow, that's a nice house. I really like that house. I'm gonna buy it no matter what, right? So, and then if you don't do a complete inspection, you don't do a complete detailed view of the house, you may be missing some key factors here. So if we don't kind of see what's on the inside, we don't see what's around on the back, you may be missing out. So this would be a standard cardiac monitoring. This is just standard limb lead monitoring, leads 1, 2, and 3. So this may be a 12 lead. So notice if you're just only doing cardiac monitoring with standard limb leads, could be missing something very significant and detrimental. So who should have a 12 lead? So it's not just people with chest pain. Really, if you think of anybody with complaint from neck to navel, and just a few examples, maybe somebody weakness, epigastric or abdominal pain, nausea, paleness, left arm pain, chest pain. So it could be a multitude of things. So in a medical aspect of it, if they're complaining about some non-specific and not just chest pain, so keep that in mind, anything unexplained from neck to navel, it is ideal that we can run it and obtain a 12 lead on this patient, because you could be missing out if you don't do, again, a good history and a good assessment. Could be missing out on things. And one of our assessment tools that we have, in addition to cardiac monitoring, is 12 lead ECG. So you could miss out on some things and recognize any of these as far as suspecting to have some type of cardiac event. And that's our key factor on the 12 lead ECG is, can we apply 12 lead for somebody who's just complaining of weakness or nausea, or maybe just looks ill just in general appearance without specific complaints, to run a 12 lead to help determine what could be going on. Is it something cardiac related? So the type of ECG leads that we're looking at with a 12 lead are bipolar, unipolar, and precordial. So we're looking a little bit more of these. So bipolar leads are going to be your limb leads, leads 1, 2, and 3. So these measure the electrical difference between two limb electrodes, both a positive and negative. And think back about Einthoven's triangle. So this is bipolar leads. They basically form Einthoven's triangle and provide frontal plane views of the cardiac activity. Again, just a frontal plane view. We're not looking for anything else in the bipolar leads. So here's Einthoven's triangle. Remember, our right arm is always negative. Our left shoulder or left arm is positive in lead 1, negative in lead 3. Electrical flow, ideally right arm toward left leg. So that's going to be our markering lead in lead 2. So our right shoulder, right arm is negative, our left leg is positive. The flow of electrical current should be going toward that positive electrode, which then yields you a positive or upright waveform. So lead 1 goes from right arm to left arm, lead 2, right arm to left leg, and lead 3, left arm to left leg. And lead 3, the left arm is negative, our left leg is positive. And then we have unipolar leads. These are augmented limb leads. And this is where we get AVR, AVL, and AVF. So AVR is augmented vector rod. This positive electrode is on the right arm. AVL, the positive electrode is on the left arm, and AVF, the positive electrode is on the left leg. So these three leads measure electrical activity in the frontal plane, which is a vertical view through the heart, as if you're looking at the patient from the front. So you're looking front toward me, and this is the view that we're getting. We're only getting stuff on the anterior part, or just basically through. We don't get anything horizontal view, just a vertical view. And the augmented limb leads, AVR, AVL, and AVF, are basically computer calculated to give us that view of the rhythm. So they're called augmented because the machine boosts their signal. The reference point, known as the Goldberger central terminal, is an average of the other two limb electrodes. For example, AVR's positive electrode is on the right arm, and its negative reference is an average of the left arm and left leg. So these are augmented. So an augmented meaning that the machine, the cardiac monitor, the 12-lead machine, is the one that comes up with these through computation. Our precordial leads, these are our chest leads. So this is V1 through V6. They look in a horizontal plane, whereas our unipolar and bipolar leads are only looking at the vertical plane. The precordial lead is looking at a horizontal plane. So it's basically a horizontal slice through the heart to see what's happening electrically in the heart muscle there. There are placed at specific locations on the chest, moving from the patient's right to their left. So another FYI, precordial relates to the precordium, which is the area of the chest wall covering your heart. So if you ever wonder if precordial leads, it's dealing with tissue covering your heart. So our precordial leads are V1 through V6. And if you look here and notice there's specific locations where we should place these, and we'll talk about in a moment. But V1 is looking this view. So if you were to take the heart, slice it in two and horizontally, this is the views that we are getting. So V1 is looking basically straight in toward the center of the heart. V2 is looking straight in from this angle to the center of the heart. V3, V4, V5, and V6. Now, if we're going to do a 15 lead, we would have V4R here. We'd have V7 and V8 around the backside. Still in that same planar view is looking from the outside in horizontally, looking at the heart. So lead placement, and lead placement should be as close to accurate as possible, and positioning is utmost importance. Improperly positioned limb leads, improperly positioned precordial leads can yield false negatives or false positives. So you may mistake somebody who's having a MI but they're really not, because we don't have proper placement, or may be missing that MI because we have improperly placed leads. So V1 is going to go in the fourth intercostal space between on the right side of the sternum. V2 is going to fourth intercostal space looking on the left side of the sternum. V3 is midway between placement of V2 and V4. V4 is fifth intercostal space to the midclavicular line. So midclavicular, go down fifth intercostal space, V4. Then we have V2, fourth intercostal space. V3 should go right between the two, midway between V2 and V4. V5 should be midway between the placement of V4 and V6. So V6 is going mid-axillary line, so mid-axillary, fifth intercostal space, and then V5 should go between V6 and V4. As far as your limb lead placement, those electrodes, where should they be placed? They should, just for routine cardiac monitoring, you can put them anywhere on the body, right? So we can put them on our chest, ideally for a 12 lead. And why it's important on 12 lead is later on we look at axis deviation. If you do not have your limb leads properly placed, then it can skew axis deviation and give you some false readings there. So your limb leads should go beneath the shoulders, ideally toward the wrist, and beneath the hips, ideally toward the ankles. So it gives us a true perspective and a broader view, if you will, of the true electrical components and processes going on in the heart. Should avoid any bony prominence or around on your limb leads. So the importance of properly placed leads connects directly to clinical accuracy and patient safety. Again, we're looking for clinical accuracy. We're not just trying to do a 12 lead just to say we've done it. We should be doing this for the benefit of the patient, either confirm or deny. And this 12 lead in itself does not deny or rule out a heart attack. It can help confirm one, but it does not necessarily rule one out, because you could have non-STEMIs or some other issues going on. But it's just an assessment tool to help us determine what could be going on with the heart. So we're looking for clinical accuracy. So if you do not have properly placed electrodes, then you're not going to have a clinically accurate representation of what's going on. And we're also looking for patient safety. So, and we also, again, benefit of the patient, we should be doing what's in the patient's best interest, not ours. So improperly placed leads may mimic STEMI when none exist, may hide true ischemia. If you do not have those properly placed, just a centimeter off, up and down on improperly placed one may mimic a STEMI, or it may cause you to miss a STEMI. Can cause incorrect axis deviation or bundle branch block patterns, and the proper placement promotes consistency for monitoring changes. So we also have to consider this, and it goes back to clinical accuracy and patient safety, is that early activation of the cath lab. So if you happen to be working in a region that has EMS activation of the cath lab, you have to be proficient at that. Otherwise, you get a lot of false positives, if you will. So anyway, that's a brief overview. We'll talk a little bit more in detail about bundle branch blocks, axis deviation, ST elevation, ST depressions, and some other stuff with 12 leads that you cannot get from standard limb lead monitoring. So anyway, thank you, and continue on with your journey in 12 leads.